Medical College, and she's a very passionate teacher. She is going to teach you some spotters. So she's going to take you through some spotters, and you are supposed to answer on the chat box. And ma'am will then try and see where you're going wrong, and she'll tell you how to approach this important part. So in the examination, now we have OSCEs, but you can have some spotters also in other examinations in your university. So in the spotters, it's a good this thing to get many marks. So spotters are clear marks. It is not based on how you are saying what in your case or whatever. So it's a good scoring part is the spotters. So Dr. Radhika, please take over. Thank you for being here today, Dr. Radhika.
Thank you, ma'am, for having me here, and a very good afternoon to all of you. As ma'am has said, we shall run through a couple of spotters, and you can type your answers in the chat box, and I shall be explaining few salient features as we go along. So this is the first one. Yes, so that is a case of bilateral pheochromocytomas. That's right. And we have avidly enhancing masses in bilateral suprarenal regions, as we can see here on these coronal and axial contrast and sections of the abdomen. And these are very hypervascular mass lesions, so they enhance a lot. And we are all familiar with the 10% rule, which says that 10% are malignant, 10% can be extrarenal, they can be bilateral, familial, not associated with hypertension seen in children, and 10% may show calcification. Yes, and if you see bilateral pheochromocytomas, then one should suspect von Hippel-Lindau syndrome, MEN2 and 2A and 2B, neurofibromatosis 1, and familial paraganglioma syndrome. So that is right. This was a case of bilateral pheochromocytomas. Coming on to the next one. So a relatively simple one there. Yeah, this is a hysterosalpingography showing bilateral hydrosalpinx. We can see dilated tubes on both the sides, and this is the uterus here. So this is a case of bilateral hydrosalpinx. That's the next one. Yes, so that is herpes encephalitis, typical picture there. It is the most common cause of fatal sporadic fulminant viral encephalitis, and there is a bilateral asymmetric involvement of the limbic system, the medial temporal lobes, insular cortices, and the infralateral frontal lobes. So here we can see with this T2-weighted axial MR image, there is evidence of hyperintensity in the frontal regions, the temporal regions along the insular cortex, very well appreciated on the coronal FLAIR images. It shows restricted diffusion. So my answer as bilateral infarcts. Now, this is not an infarct because if it is an MC infarct, then the basal ganglia will also be involved. So that is an important feature that helps us to differentiate HSV encephalitis from infarcts, that the basal ganglia are spared. So this is a case of herpes encephalitis. Coming on to the next one. Okay, so this is a collapse of the left lung, which is causing a wide opaque hemithorax on the left side. It's because of collapse of the left lung because of a malpositioned endotracheal tube. We can see the left bronchus here, and there is a near complete opacification on the left hemithorax, sorry, and that is because of a misplaced endotracheal tube. We can see it going into the right main bronchus, causing a collapse of the left lung. It is not a case of massive pleural effusion. If it would have been a whiteout, an opaque hemithorax because of an effusion, there would have been a contralateral mediastinal shift. So here there is evidence of volume loss, right? So there is an ipsilateral tracheomediastinal shift, there is an opaque hemithorax, so there is volume loss, and that is because of the malpositioned endotracheal tube. A good position for the tube would be when the tip of the endotracheal tube lies 5 to 7 centimeters above the carina or at the level of the medial end of the clavicle, as we can see here on this radiograph. And on these examples here, these are wrong positions. Here we can see it going into the right bronchus. Here it is too close to the carina. So that is a malpositioned endotracheal tube. Moving on to the next one. Yes, so I see one correct answer. That is a right-sided emphysematous pyelonephritis. On this abdominal radiograph here, we can see a lot of motile lucencies in the right flank region overlying the right renal fossa here. There's a lot of motile lucencies and streakiness here with evidence of air in the right renal fossa. So this was a case of an emphysematous pyelonephritis. It is a life-threatening condition, and there is a gas formation within or surrounding the kidneys, and it is associated with diabetes mellitus in majority of the patients. And it needs to be picked up and diagnosed and treated quickly. Otherwise, it is associated with a high mortality rate. And there can be motile streaky air lucencies within the renal parenchyma, and this can also be associated with air fluid collections within or surrounding the kidney. So this was a case of an emphysematous pyelonephritis. Yes, so fairly easy one there. There's evidence of a well-defined lesion in the retroperitoneum, which shows cystic areas. It shows areas of fat attenuation as well as calcification. So that was a case of a retroperitoneal teratoma, not a lymphoma, no, not intussusception. It's a very well-defined mass, and it shows presence of fat and calcification. It's very well-defined. So this was a case of a retroperitoneal teratoma. So this was a young female who had history of obstructed labor. Yes, so that is a vesicovaginal fistula. If you see here, we can see a double density. There is contrast in the bladder and there is contrast here in the vagina posteriorly. So there's a double density that we can appreciate here in the pelvic region on this IVU film. So this was a case of a vesicovaginal fistula secondary to obstructed labor. There was a fistulous communication between the bladder and the vagina. Moving on to the next one. Yes, so that is a horseshoe kidney with calculi on the right side. We can appreciate a soft tissue density shadow here in a U shape along with presence of calculi. Yes, so this is a horseshoe kidney with calculi on the right moiety. It is the most common renal fusion anomaly. It's more commonly seen in males as compared to the females, and it can be either a U-shaped or the inverted U-shape depending upon the site of fusion. And the complications associated with a horseshoe kidney are UPG obstruction. There can be calculi infections. Tumors may occur in horseshoe kidneys. And also, because of their position, they are predisposed to trauma. Moving on to the next one. Yes, so that is a case of a uterine leiomyoma with cystic degeneration on these axial and coronal sagittal reformations. We can see that there is evidence of a well-defined heterogeneous lesion which is arising from the anterior myometrium, and it shows a central cystic area. So this is a case of cystic degeneration in a leiomyoma. Leiomyomas are the commonest uterine neoplasms, and when they outgrow their blood supply, as they enlarge, they can undergo degeneration. The most common type of degeneration is hyaline degeneration, but the others that can be seen are cystic, myxoid, and red degeneration. And cystic degeneration will appear similar to fluid on imaging. So that is a case of cystic degeneration in a leiomyoma. That's right. That is a case of a transitional cell carcinoma of the urinary bladder. As we can see here, these T2 weighted images, there is evidence of intraluminal projection here, a growth which is arising from the left lateral aspect of the urinary bladder. It shows contrast enhancement on the post-gadolinium scans. So this is a transitional cell carcinoma of the bladder, and MRI is the modality of choice for locally staging these masses. Moving on to the next. Yes, so that is a case of acute pyelonephritis. We can appreciate a striated nephrogram. We can see alternating areas of hyperdense and hyperdense areas in the renal parenchyma, and the kidneys also appear bulky on both sides. And the various causes of striated nephrogram are enlisted here. Can be because of acute pyelonephritis, ureteric obstruction, contusions, renal vein thrombosis, tubular obstruction, hypertension, and also because of autosomal recessive polycystic kidney disease and acute radiotherapy to the kidney. Moving on to the next. Yes, that is a case of Marsh fracture. Here we can see a fracture, the neck of the second metatarsal here. So this is because of fatigue or a stress fracture, repetitive trauma to a normal bone. Moving on to the next one. This is a case of an epidermoid cyst of the testis. It is a rare benign testicular tumor seen in the second to fourth decades, and on the ultrasound, we can see a well-defined lesion in the testis. It gives the bullseye appearance or the onion skin appearance with this whorl kind of pattern, and it is an avascular mass. There is no vascularity inside, a fairly typical characteristic image of the epidermoid cyst of the testis. Seminomas will tend to be more homogeneous, so this is not a seminoma. This is an epidermoid cyst of the testis. Yes, so that is a renal cell carcinoma of the left kidney. There is a heterogeneously enhancing mass arising from the left kidney, which is associated with a hypodense filling defect in the IVC, along with multiple hepatic metastasis. So this is a left renal cell carcinoma with IVC thrombosis and hepatic metastasis. next one. Yes, this is an acromioclavicular dislocation with increase in the joint space, which will normally be 5 to 8 millimeters. So there is a definite increase in the acromioclavicular joint space, a case of acromioclavicular dislocation. And if it is subtle, then you can compare to the other side. If there is a discrepancy of 2 to 4 mm between the two sides, then it is significant. Yeah, so this is a case of ectopic neurohypophysis. We can see that the posterior pituitary bright spot is not where it should be. It's seen here superiorly. So this was a case of an ectopic neurohypophysis. The posterior bright spot is also seen well on these corneal images here. It's not a cellar or a supracellular mass, right? So we can see the pituitary gland here in the cella, and there is no mass which is there in the pituitary fossa or in the supracellular cistern. So not a Rathke cell clefts, not a macroadenoma, not a germinoma. This is an ectopic neurohypophysis. It's not a hypothalamic hamartoma either. There is an abnormal location of the posterior pituitary bright spot. Moving on to the next. This is an adult patient, and in this, the axial CT contrast and CT sections show presence of multiple hypodense lesions within the renal parenchyma. This is a case of renal lymphoma involving both the kidneys. Renal lymphoma is usually seen in widespread NHL, and there can be various imaging patterns, multiple lesions in both kidneys being the commonest. They can also present as solitary lesions or as direct extensions into the kidney from retroperitoneal lymph nodes. There may be just perinephric disease with a rind of homogeneous perinephric soft tissue, and there may be nephromegaly and venous sinus involvement as well. So those are the imaging patterns of renal lymphoma. Renal infarcts would be more wedge-shaped and they won't have so much of mass effect. Pyelonephritis also would have a typical striated nephrogram, as we've already seen. And this was an adult patient with bilateral renal lymphomas. So again, a characteristic imaging appearance there on the eye view. There is a retrocaval ureta, also known as the circumcaval ureta. It is a rare congenital anomaly and is actually an anomalous development of the infrarenal IVC. So it can be of two types, the type 1 or type 2. In the type 1, the ureta crosses behind the IVC at the level of the L3, and we get a typical fish hook, seahorse, or a reverse J appearance of the ureta. It is associated with moderate to severe hydronephrosis. And in the other type, the crossover occurs at a higher level, and there is a sickle-shaped ureta and lesser degree of hydronephrosis as compared to type 1. The type 1 is more common. Yes, so that is a case of bilateral angiomyolipomas. We can see multiple lesions with fat density within, replacing the renal parenchyma on both the sides, and with such extensive involvement bilaterally, this was a case of tuberous sclerosis, bilateral renal angiomyolipomas. So I think by far everyone got this one right. That's excellent. Moving on to the next. So this was a case of multiple Brown's tumor in hyperparathyroidism. We can see multiple expansile lytic lesions in the pelvis on both the sides, involving both the femur as well. And there is thinning of the cortex here. And this was a case of Brown's tumor. So yeah, a differential can be metastasis, but the age is 19 years. So Paget's and multiple myeloma are not likely. Paget's can also have areas of cirrhosis within. Metastasis, yes, can be a differential, but not Paget's. Myeloma also not in this age. It was a 19-year-old female, as was highlighted here. Fibrous dysplasia will have a ground glass matrix, so not very well appreciated here. This was the corresponding X-ray of the wrist, which makes the diagnosis clearer. There is subperiosteal resorption of the bone, as we can see along the phalanges here. This is well appreciated on the radial aspect of the proximal and middle phalanges. So this was a case of hyperparathyroidism with multiple Brown tumors. Yes, so this is a case of miliary nodules. There are multiple tiny nodules which are scattered in bilateral lungs. So miliary nodules, differentials most commonly include tuberculosis. It can be seen with fungal infections like histoplasmosis. Pneumoconiosis could be one reason, sarcoidosis, and metastasis, especially from renal cell carcinoma and thyroid carcinoma. So this is a case of miliary nodules, a case of miliary tuberculosis. Yes, that's very well picked again. That's a typical characteristic double PCL sign, which is seen with a bucket handle meniscal tear. We can see a double PCL sign very well here. There's a presence of some amount of joint effusion. Yeah, so that's a typical sign. Not the PVNS. We don't see any hyperintense focal areas around the knee joint. So yes, this is a bucket handle meniscal tear. Yes, so that's a good pick. All of you have picked it up. It's a left superior vena cava. As you could see here, lateral to the aortic arch, there is a vessel in the mediastinum. Normally, you do not see a vessel in this location here. So this was a left superior vena cava, which is because of failure of obliteration of the left common cardinal vein. You can see a vessel which courses vertically in the mediastinum, lateral to the aortic arch. Most commonly, it drains into the right atrium via the coronary sinus. In majority, the right-sided SVC is also present. There is an increased likelihood of congenital heart disease if there is no right SVC, or if the left SVC drains into the left atrium. This is important to pick and report because it has an impact on procedures that require upper limb venous access. And these may also be associated with increased risk of arrhythmias and congenital cardiac defects. Moving on to the next. Yes, so that is again a quick response and a correct one too. There is a left lower lobe collapse giving rise to a double heart border sign, the left lower lobe collapse seen as a triangular opacity here in the retrocardiac region. This is the next one. Yeah, so a lot of correct answers pouring in for this one as well. This is a skeletal survey in a case of mucopolysaccharidosis. We can see a dolichocephaly in the skull here. We can see proximal pointing of the metacarpals, which are also widened. And there is a beaking of the vertebrae. There is a flaring of the iliac wings with constriction at the iliac bone base, along with metaphyseal flaring. So yes, correct. That is a case of mucopolysaccharidosis. So yes, this is a case of a neuroblastoma. Here we have axial and coronal contrast enhanced CT images, which show presence of a heterogeneous mass in the retroperitoneum, which is crossing over to the other side. There are areas of calcification. It is lifting the aorta off the vertebra, and this was a child, a small child, a case of a neuroblastoma. So neuroblastomas tend to cross the midline. They're associated with calcifications. They may show extension into the chest or into the spinal canal as well. And this lifting of the aorta from is quite a characteristic feature, which is seen with neuroblastomas. So this is a case of a pituitary macroadenoma. We have MR images here, T1 sagittal, T2 coronal, and the sagittal post-contrast images, which show presence of a mass which is arising from the pituitary gland extending into the suprasellar region. And it shows a typical snowman or figure of 8 appearance. So this was a case of a pituitary macroadenoma. So a couple of you have got this one right. This is a case of congenital pulmonary adenomatoid malformation. Here we can see presence of a cystic mass within the fetal thorax. Here on this side, which is compressing the other lung, we can see the heart also, which is shifted to the other side. This is the normal lung, and this is the multicystic lesion, which is seen here. And this was a case of a CPAM, which was picked up on fetal MR here. So this is the most common fetal lung mass, which is diagnosed in the neonatal period. It's mostly unilateral, affects an entire lobe, and it shows rapid growth between the 20th to 26 weeks of gestation. And most important prognostic factor here is presence of hydrops, and the risk of hydrops can be estimated by calculating the CVR, which is the CPAM volume to head circumference ratio. And if this is more than 1.6, there is a high risk of hydrops. It appears as a multilocular cystic lesion on T2-weighted images, as we have seen here. Moving on to the next. Yes, so this is a case of a cross-fused renal ectopia here. We can see both the renal moieties on the same side, and these are the two ureters. Cross-fused renal ectopias, they are rare anomalies, again more common in males as compared to females. And the most common subtype is left to right ectopia with inferior fusion. They are usually asymptomatic, but they may present with pain, mass, dysuria, and hematuria. The urethral orifices are usually orthotopic, but they can be ectopic in 3% of the cases. And again, the associations can be VUR, uretroceles, nephrolithiasis, UPG obstruction, and carcinomas. So these are the 6 subtypes here. They can be an inferior ectopia, they can be an S-shaped ectopia, they can be a lump kidney or a disc kidney, they can be an L-shaped kidney, or it can be a superior ectopia. So these are the 6 subtypes of cross-renal ectopia. Yes, so I did see one correct option there. This is a case of a urethral calculus. Here we can see a radiopacity. So very important to look at all corners of the films, especially the hidden ones, so as to pick up the subtle anomalies. There is a partial duplication on the right side. Yes, that is there. But the finding I was looking for is this urethral calculus here. Medialization of the ureters, no, they're not going to medial. So there is some hydronephrosis on the right side along with a partial duplication, but what I was looking for here is a urethral calculus. Yes, so I did see one correct answer there. Very well picked up. This was osteochondroma, which is arising from the left clavicle here. We can see this bony growth, which is arising from the clavicle, pointing medially. So an osteochondroma of the left clavicle. Moving on to the next. Yeah, so there is a bilateral tubal block, bilateral corneal block, but yes, there is also presence of these tooth-like structures here in the left hemipelvis. And so this was a case of a teratoma along with a bilateral tubal block. So there is a right-sided DJ stent, yes, and it can does appear to be not seen in its entirety, could have been fractured, but yes, there's also fine syndesmophytes which is seen along the vertebral margins. So this was a case of an ankylosing spondylitis. I want you to note to appreciate all the findings. Look at the corners of the films, look at the bones, and that will help you to pick up these ancillary findings. So this was a case of ankylosing spondylitis with fine syndesmophytes along the vertebrae. So there is a lipoma, but it's an interhemispheric lipoma, which is associated with corpus callosal agenesis. So we can't see the corpus callosum well here, and there is presence of a lesion which shows signal intensity similar to that of fat. It appears hyperintense on T1 as well as T2 weighted images in this wider interhemispheric fissure. So this is an interhemispheric lipoma along with an absent corpus callosum, so a corpus callosum agenesis. So this is ileocecal tuberculosis. Here there is narrowing and ulceration at the ileocecal junction with a gooseneck deformity in a case of ileocecal tuberculosis. Moving on to the next one. Yes, that's a correct answer for most of the participants. That is a torus fracture. There is a focal bulging here at the metaphyseal diaphyseal junction of the bones, and commonly seen in children because of trabecular compression from axial loading. So it's important to trace all the cortices of the bones and to look for these tiny bumps. Yes, so these are pleural plaques. We can see these geographical areas bilaterally here, and some of them are showing areas of calcification. And this is the holly leaf sign because of these thick nodular rolled edges, which are similar to the holly leaf here. So yeah, these are bilateral pleural plaques. They tend to spare the apices and the costophrenic angles, as also evident on this radiograph. And if they are very extensive, then yes, most commonly they are associated with asbestosis. Okay, so a lot of correct answers pouring in. Yes, that is a bare orbit sign on the left side with the absent innominate line. As we can see the innominate line well on the right side, but we cannot appreciate it here on the right. So this is a bare orbit sign, and the causes of bare orbit sign include sphenoid wing dysplasia in NF1, as was in this case, but it can also be seen with neuroblastoma metastasis or sphenoid wing meningiomas. So there is, along with absent innominate line, there is also an enlargement of the anterior orbital rim and egg-shaped enlargement here. So a bare orbit sign, and these are the corresponding CD and MR images, which show the changes in the orbit well on this VRT image here. There is a sphenoid dysplasia, and we can appreciate the presence of the plexiform neurofibroma here on these MR images in a case of NF1. Yeah, so that is again a typical one, a hyperdense area in the superior aspect of third ventricle, a colloid cyst. And these are benign epithelial line cysts. They appear hyperdense on CTs, and they are attached to the superior anterosuperior aspect of the third ventricle. And they may be asymptomatic or present with severe headaches and hydrocephalus also. That's the last one for you. Yes, so very well picked up there. This was a case of synovial chondromatosis. We can see presence of multiple radiopaque symmetrical densities here surrounding the shoulder joint, and the shoulder joint per se looks all right. So this was a case of primary synovial osteochondromatosis. It is a benign monoarticular disease which can be seen from the third to the fifth decade. And it is because of metaplasia of the synovial lining of the joints, bursae or tendons into cartilaginous nodules. One can appreciate a widened joint space, and in the MR, they can be seen as multiple foci of low signal intensity if they are mineralized, or if they're not mineralized, then they show a high signal on the MR, which is typical of any cartilaginous tissue. And on the primary synovial chondromatosis, the joint will be normal, as was in this case, contrasting from the secondary form, which is seen with osteoarthritis or trauma. So thank you all for your kind attention. With that, I come to the end of my presentation.
Thank you, Dr. Radhika. That was an excellent presentation for the typical spotters that come in the exams. You covered a wide variety of spectrum of the body parts and the systems. There are a few things that I'd like to see after seeing the responses. So first is that please see all the corners of the film. Take your time, look at the corners of the film, make a system that if a bone x-ray comes, how are you going to look at it? Secondly, it may not, once you have one finding, look for the second finding also. What is called a satisfaction of search. Don't give up with the first finding. Like that x-ray that Dr. Radhika showed with the DJ stent, and actually it was ankylosing spondylitis. So be careful in such x-rays. And the pickup of the osteochondroma left clavicle is very well done because the x-ray chest was normal. So whenever you have a normal looking x-ray chest, always look at the bones. look under the diaphragm as well for any pathology. Then in the IVP film, one of you had written ureteric stricture. So ureteric stricture cannot be said on one film of the IVP. That is one thing people must be absolutely sure about, that you have to, even in the exam, you can ask the examiner, I want to see more than one spot of the IVU. And somebody had written bladder spot for a bladder, I think it was one spotter. So bladder, whenever you have to comment on calculus, you always can ask the examiner for a plain film. This is for your case, I'm saying. So otherwise it was, people did attempt it, and we got a lot of good questions, a lot of good answers to this as well. So I think somebody has written any tips for OSCEs. So tips for OSCEs is that please work in your departments for 3 years, because OSCEs are basically clinical questions. For example, if what would be the patient profile like? So you should know the patient would be diabetic, patient would be very sick, and what would be the management for these patients. So a patient emphysematous pyelonephritis, apart from antibiotics and all, maybe it's an urgent surgery or a nephrectomy, maybe the answer. So you, whatever cases you come across in your, especially for the first year DNB residents, since OSCEs are here to stay, whenever you see a case, see the case sheet, talk to the patient when they come to the ultrasound, know how they present, know what are the typical pictures, the blood profile like, because this cannot be taught in a day. OSCEs cannot be taught. It is how much you have learned as an intern and as well as in the in your clinic, in your radiology, 3 years of radiology as well. So I think that is from me. Dr. Radhika, would you like to comment upon the answers that you got, and how do you think they should prepare?
Yeah, ma'am, there were quite a few correct answers. It was heartening to see that. Yes, and for preparation, I think the more they see, the more they learn, and the more they work, I think that will help in their experience and their, they'll be well versed with things once they take it heads on. I mean, there's so much which is available on the net and in terms of books and material to read. But I think when it comes to practically seeing cases and just doing it for your own self, that's what makes your learning complete, and it stays with you for a long time.
So, Dr. Radhika, there was one, they wanted to see some spot number 9 again, I think. So we cannot show you all the spots. The doctor, since there is a bit of time, I'll request Dr. Radhika for the 9th spot.
Okay, ma'am.
Then there was a question on limbic encephalitis. So limbic encephalitis generally also involves the basal ganglia, and herpes simplex encephalitis, the presentation is rather dramatic with fever and all that. So the clinical picture as well as the radiology, the appearances are different. Okay, this one.
Okay, so this was a case of a cystic degeneration and a fibroid. This is the uterus here, and this hypodensity here is the endometrium. And there is a hypodense lesion which shows cystic areas within, which is arising from the anterior myometrium.
So sometimes in the spotters, it may not be very very obvious, or it may be difficult, or there will be one or two spots which may be tricky or maybe controversial in your exam as well. So what you should do is, in that, only in that case you can describe. Otherwise your marks get cut if you write a description, or you give two things, which one of them is possible and one of them is a diametrically opposite things. So if you write like that, then the marks are deducted in the examination. Try and make a habit of writing right, left, if there's sort of sort of say a fracture is given on and both femur are shown, so you write fracture of the right femur. Try and write it like that, I think. So is there any other question? I think we are done with this. So thank you, Dr. Radhika, for your excellent effort and time and patience. And thank you, dear students, also, because it was a very good session. We got good responses, and I'm very happy to see a lot of good correct answers. So there is definitely good teaching going on in your centers. And I think by the response that I have got, I think we'll show more and more of these exam-oriented sessions will also be taking place in the coming few months or whatever. So Navneet ji, over to you now to wind up.
Thank you, ma'am.
Thank you very much, Dr. Radhika Batra, for the presentation, and thank you very much, Dr. Anjali Prakash, for joining us. And thank you, trainees, for joining us.